Our next speaker is Dr. Aliyah Khan. Dr. Khan is a professor of clinical medicine at McMaster University. She is the director of the Calcium Disorders Clinic and the Fellowship in Metabolic Bone Disease at McMaster University. She has published over 200 scientific papers and numerous books and chapters on osteoporosis and parathyroid disease. Being an outstanding contributor and educator, she has received numerous national and international awards, which include Queen's Diamond Jubilee Medal for Excellence in Clinical Care, Research, and Teaching, International Hypoparathyroidism Award, International Osteoporosis Foundation Award, and recognition by Osteoporosis Canada for outstanding contribution to research and education. It's certainly our privilege and pleasure to welcome her here, and she's going to speak to us on a primary guide to key clinical questions in osteoporosis management. Dr. Khan.
Thank you so much, Dr. Axler, and good morning, everybody. It really is my pleasure to speak to you today about key clinical questions in osteoporosis management. So I'm just going to move over to my next slide. And these are my disclosures. I have received research support from a number of the industry partners for the development of new molecules for the treatment of osteoporosis and parathyroid disease. And I will also be receiving an honorarium for this presentation from Amgen. And I am the chair of the Rapid Response Committee of Osteoporosis Canada, ASBMR Ambassador to Canada, and Scientific Advisor to the International Osteoporosis Foundation. And these are additional disclosures, and you have these in your handout material. And this program, as you know, is an accredited program. All right, so these are the key clinical questions that we're going to be addressing. And the first question is, how do we diagnose osteoporosis? And how does this differ from an assessment of fracture risk? Our second question is, how do we evaluate fracture risk in postmenopausal women in terms of identifying who will be eligible for therapy? And the last question is, how long should we be treating people with osteoporosis? So let's begin with the first question. So how do we make the diagnosis of osteoporosis? And how does this differ from assessment of fracture risk? And these are the learning objectives. By the end of this module, you will definitely be able to assess fracture risk, and you will know who to screen and how to screen. And also you will be able to explain the factors that determine osteoporotic fracture risk. So let's talk about how we make the diagnosis of osteoporosis. So there's two ways that we can make the diagnosis of osteoporosis. Osteoporosis is diagnosed clinically in the presence of a fragility fracture. So if our patient falls from standing height and experiences a fracture, then they have evidence of impaired bone strength. And that means that the quality and the quantity of bone is insufficient to maintain the integrity of the bone. And so if a fracture happens with a fall from standing height, that confirms a clinical diagnosis of osteoporosis. The sites that do not count as fragility fracture sites are face, hands, feet, and ankles. All other sites are considered valid sites to make a diagnosis of osteoporosis. The major osteoporotic fracture sites are hip, spine, forearm, and humerus. So these are major osteoporotic fracture sites. And so this is how we make the clinical diagnosis of osteoporosis. What about the densitometric diagnosis of osteoporosis? To make the densitometric diagnosis of osteoporosis, we need to have a bone density assessment completed. And a densitometric diagnosis is possible in postmenopausal women and men over the age of 50. And a densitometric diagnosis of osteoporosis is not possible without a fragility fracture in younger men under 50 and in premenopausal women and in children. So in in women who are eugonadal or are having monthly periods and their estrogen levels are normal, they're in the premenopausal reference range, we cannot make a diagnosis of osteoporosis purely on the basis of the bone density test. So 2 ways to diagnose osteoporosis, and you don't have to have both. The clinical diagnosis is the presence of a fragility fracture. The densitometric diagnosis is a low T-score in a postmenopausal woman or a male over the age of 50 and older. And the areas that we evaluate are the lumbar spine. It has to be at least more than 1 vertebral level. We don't base the diagnosis of osteoporosis on 1 vertebral level. So if you have to have at least 2 vertebral levels to be a valid spine assessment. The total hip, the femoral neck, or the 1/3 radial site. Those are all valid sites with a DEXA assessment to assess in terms of identifying if our patient has osteoporosis or not. And if they have a T-score of -2.5 or less at the lumbar spine, femoral neck, total hip, or 1/3 radial site, then our patient has osteoporosis. -2.5 or less at any of those sites, T-score of -2.5 or less confirms the diagnosis of osteoporosis. Now, this is different to fracture risk because fracture risk will determine what is the risk of our patient having a fracture over the next 10 years. Let me just turn that off. And fracture risk is determined by a number of factors. Bone density tells us what the quantity of bone is like in the region of interest. It doesn't tell us anything about bone quality. It doesn't tell us anything about the collagen fibers, the mineralization of the skeleton, the health of the bone cells. It doesn't tell us about many factors that determine the risk of fracture with impact. And so, to understand what is our patient's fracture risk, we take the information that we get from the bone density assessment and integrate it with other important clinical risk factors for fracture. So let's talk about this. And we need to ask our patient, one of the most important risk factors for fracture is age. As our patients are getting older, they're going to have changes in the function of the bone cells. So we have osteoclasts, which resorb bone and dig a resorption pit. We have osteoblasts that move in and fill in that resorption pit with osteoid, which subsequently mineralizes. And then we have osteocytes, which are sensing the stress and strain in the microenvironment and regulating the entire remodeling process. And we've actually discovered a new cell, the osteomorph. And the osteomorph is an osteoclast that splits with fission and becomes osteomorphs. And these, in the presence of rank ligand, can become osteoclasts again. So there's a lot of changes happening in the skeleton with age. For example, these osteocytes become bald osteocytes so that their ability to sense the stress and strain in the microenvironment is impaired. And our older patients will have neuromuscular changes, which will impact their fall risk. And if someone is more likely to fall, they're also more likely to fracture. So there are changes that happen in the skeleton with age. And the BMD fracture risk relationship is age dependent. So the age of our patient is critical in determining our patient's fracture risk. So if our patient has a T-score of -2.4 and she's 50 years old, then her fracture risk would actually, in the absence of other fractures or other risk factors for fracture, would be classified as low. But if she was 85 years old, her fracture risk just based on her bone density would be high. So the impact on fracture risk is clearly age dependent. And we need to know what our patient's age is and integrate that bone density with age to determine our patient's fracture risk. Similarly, if someone has had a fracture, that denotes an increase in the risk of fracture. And we advise that we clearly and carefully evaluate a history of prior fracture. And I ask my patients, have you had a prior fragility fracture? And they don't know obviously what a fragility fracture is. So I ask them to tell me about all the fractures they've had from birth till now. And I grade them. How did it happen? Was it a fall from standing height? Were you standing on the table or were you standing on the floor when you fell? And what did you break? And then I determine, was it a fragility fracture? Because this will help me to diagnose the osteoporosis, even if they have a normal bone density, and evaluate their fracture risk. Did their parent have a hip fracture? This will determine their risk of fracture. Have they been on steroids? If they've been on 5 milligrams of prednisone for 3 months or longer, in the FRAX calculator, that will have an impact on fracture risk. In CAROC, we actually say 7.5 milligrams of prednisone for 3 months or longer, and it's cumulative exposure in the previous year. We need to look at the presence of secondary causes of osteoporosis, comorbidity, such as rheumatoid arthritis, hyperparathyroidism, hyperthyroidism, chronic obstructive lung disease, liver disease, celiac disease. All of these conditions will have an impact on the fracture risk. Are they on drugs that can cause osteoporosis, such as steroids? And there are many other drugs such as aromatase inhibitors and GnRH analogs, and we can go on and we'll go over the drugs as well. Have they been smoking? I need to know, were they heavy smokers? Are they current smokers? Are they past smokers? And is there a history of alcohol excess now or in the past? Because if it was a history of alcohol excess in the past, this will help me to understand why my patient's bone density is the way that it is. Or if they've had a hip fracture, why did they have a hip fracture? Or why did they have the vertebral fracture? And we also need to know about gonadal status. When was menarche? Was it early? Was it late? When was menopause? Was it early? Was it late? So in women who have had a late menarche and an early menopause, the years that they've been estrogen replete are limited, and that will impact their attainment and maintenance of peak bone density. And obviously, we need to look at fall risk. When we evaluate them, we're going to look to see if they have dorsal kyphosis. If we find evidence of dorsal kyphosis, then we have to do x-rays with the thoracic and lumbar spine. We're looking for vertebral compression fractures. Because if we find one, we need to know, how did this fracture happen? Did you fall out of a tree or from a significant height, or had a motor vehicle accident? Or did you just develop this spontaneously? In which case you have osteoporosis and you have a very high fracture risk. Has there been height loss? If it's been 2 centimeters or more, then we need to do spinal x-rays. And we also look at the rib to pelvis distance. And if it's less than 2 to 3 finger breadths, then that indicates that there has been evidence of dorsal kyphosis, and we need to do spinal x-rays. And we can also measure the occiput to wall distance between our patients. And if this distance is more than 3 finger breadths, then that means that that patient is developing kyphosis. So these are important features to evaluate. It's obviously not the only feature. We know cancers can cause osteoporosis through the release of cytokines. They will increase rank ligand expression. We're going to evaluate their thyroid. We want to make sure they don't have hyperthyroidism. Listen to their heart and lungs. Chronic obstructive lung disease is associated with osteoporosis. Patients who have congestive heart failure and have decreased mobility will have obviously bone loss in association with that. Examine their abdomen, make sure there are no abnormal masses. Look to see if they have evidence of liver disease or hypercortisolism, supraclavicular fullness, dorsal fat pad. Look for all these features. Measure their blood pressure. Is your patient anorexic? Body weight is critical in determining bone health. And then to supplement our history and physical, we're going to look at our lab profile and imaging. We talked about spinal x-rays. We have to do bone density assessment if and when possible, because we know that we can also evaluate fracture risk without a bone density. We could use a tool like FRAX and input all our information without the bone density. It will give us a fracture risk assessment without bone density, which is pretty close to how useful it is in terms of predicting fracture risk with bone density. But we need to look at the bone density, lumbar spine, hip, and forearm. And we will look at spinal x-rays, as I've mentioned, looking for vertebral deformities. And we will do a lab profile because we have to exclude important secondary causes of osteoporosis. No one should be treated unless we know what the calcium corrected for albumin is. If their calcium is low, we need to find out why it's low. Is it because of vitamin D deficiency? Is it because of hypoparathyroidism? What's the cause? If the calcium is high, why is it high? Do they have cancer? Do they have primary hyperparathyroidism? Do they have granulomatous disease? Do they have adrenal insufficiency? What's the cause for the hypercalcemia? Do they have hyperthyroidism? In elderly people, patients can have hyperthyroidism without significant clinical features, and they can present with atrial fibrillation or fragility fractures. Look at the blood count. Do they have myeloma? Myelomas can cause vertebral fractures, and I recommend that every patient over the age of 50 have a serum immunoelectrophoresis, excluding a myeloma. And also we need to know renal function. We can't treat a patient without knowing what their renal function is. If the GFR is below 35 mils per minute, then we can't give them a bisphosphonate. We could, however, use denosumab all the way down to a GFR of 15 mils per minute. So we need to know what the renal function is because bisphosphonates are cleared through the kidney. And we also know that at stage 4, stage 5 chronic kidney disease, our patients may have renal osteodystrophy. And that is a totally different perspective, and we don't have time to cover it, obviously. But we need to know renal function. We cannot treat without knowing what our patient's vitamin D is. And the vitamin D should be normal. Normal is 75 to 125 nanomoles per liter. We need to know what our patient's alkaline phosphatase is. If it's high, we need to find out why it's high. We should fractionate it. Is it hepatic or is it skeletal? If it's skeletal, do a bone scan. Does the patient have metastatic disease? Do they have Paget's disease? Why is this alkaline phosphatase high? We need to know all of that information and exclude secondary causes of osteoporosis prior to starting our patient on therapy. And we obviously need to know about falls. If our patient has had 2 or more falls in the past year, this patient will need to be carefully evaluated because this will impact their fracture risk. And if they have a poor gait, they have poor balance, then we need to evaluate that and understand why. Do they have a myopathy? Is it because of vitamin D deficiency? Or is there an underlying neuromuscular condition that they need to have further evaluated by a neurologist? Do they need assistance to get up from the chair? Or can they get up without using the armrest? Are they using a walker? We can do the timed get up and go test to see how long it takes them to get up from the chair and walk 6 meters. All right, so we need to look at all of those features. And as I've mentioned, a fragility fracture is a fracture that happens spontaneously. It could just happen. They wake up in the morning, they've got back pain. And you do spinal x-rays, there's a new fracture there. And if you don't know how old the fracture is, you can do a bone scan because a bone scan will light up for 2 years after the fracture. So a fall from standing height or from a sitting position, or if they're running down the stairs, a fall from the 3rd step or lower is a fragility fracture. If they're coughing and they break ribs, or they're being hugged by a loved one or an unloved one, then they've got osteoporosis if they break a rib. That's important information that we need to know. And remember that unfortunately osteoporosis is common. And if we look at women over 50, 1 in 3 will have an osteoporotic fracture during their lifetime. And over 80% of all fractures in Canada after the age of 50 are osteoporotic. So we are very concerned about these fractures. And we know that if we look at the incidence in women over the age of 50, 22% will have a wrist fracture, 27%, like a quarter, will have a vertebral fracture in their remaining lifespan. 15% will have a hip fracture. That's pretty significant. That's like breast cancer incidence. 15% will have a hip fracture, and a hip fracture has a significant mortality associated with it. 7% will have a pelvic fracture, and close to a third will have other fractures, including clavicle, humerus, hip, tibia, fibula, hands and fingers. Hands and fingers are not fragility fractures. Almost 50% of the spine and hip fractures are associated with significant morbidity and mortality. And having these fractures are warning signs that there's a disease that we, as the patient's physician, have to uncover, evaluate, and implement effective therapy so we can prevent these further fractures. A wrist fracture is a harbinger of problems. And so many times, I see patients, they've got a cast on, they've had a wrist fracture, they're in their 50s. Oh, Dr. Khan, I don't have osteoporosis. It was just the way I fell. And we need to explain to them, that's serious. Normally, people, when they fall, they don't break their wrist. How many people were skating on the ice rink and were walking off the rink with hip fractures and wrist fractures and spine fractures? Most people fall. They walk off the rink. They don't have to get carried off the rink. So these are harbingers of problems. Look at when these fractures happen. Wrist fracture, usually in the 50s. Wrist, humerus, pelvis, vertebral fractures increase with age. And you can see that hip fractures are late events, but they're preceded by these fractures. And it's our job as our patient's physician and advocate to evaluate them. Just like we treat hypertension, we don't want them to have a stroke down the road. We're not going to wait till they have a stroke to treat their hypertension. So why should we wait for them to have a hip fracture before we treat their osteoporosis? Important point to note that if someone has had a fracture, the risk of having another fracture is highest in the first 12 months. And this is true also for hip fractures. And this is data from Denmark showing us that look at the risk of a second hip fracture. It's the highest in the immediate first several months. So this is why it's important that when someone has a fracture, we take action right away. Evaluate them, do a history, do a physical, do your lab profile. Even in a pandemic, we're not doing physicals, but we can certainly do a visual assessment, a virtual visual assessment, or even a phone assessment. And if we're concerned about height loss, then do spinal x-rays and send the lab requisition to the patient and look at that information and start them on therapy. I'm treating patients virtually and I'm starting patients on therapy. We can't allow our patients to go on to have fractures in a pandemic, especially. We don't want them to end up in hospital because the chance of getting COVID is higher if they're exposed to hospitalization. The imminent risk of fracture is the risk of fracture over the next 2 years. And you can see that after a fracture, it is the highest. This fracture is, the risk of further fracture is very steep immediately after fracture, and then the slope is going to be less steep. But we have to take action immediately. We don't have the luxury of time. These fractures are not going to happen 10 years later. They're going to happen in the next several months to a year to 2 years. And as I've mentioned, bone density is not the only indicator of fracture risk. It is one of the indicators. But if we look at who is fracturing, if you look at the BMD distribution, we can see that this is the BMD distribution, but these are the fracture rates. And we can see that fracture rates are going up with age, but a large number of people are going to have fractures. These are the numbers of fractures. And yes, as your bone density goes down, the fracture rate rises because bone density is an important predictor of who will fracture. But look at the numbers of fractures. Why are all these people fracturing when their T-scores are like -1 to -1.5? Well, the fracturing, because as I explained before, bone density is only one part of the picture. It only tells us about the quantity of bone in the region of interest, and that could be falsely elevated because if you take a vertebral body and crush it, it's going to have a falsely high bone density. Or if you've got degenerative changes, that's going to result in a falsely high bone density. Or if you've got vascular calcification, you have a falsely high bone density. And also, it doesn't tell us anything about bone quality. So for all these reasons, people are going to have fractures even when the bone density is normal. And so if we look at where the numbers of fractures are happening, approximately half of the fractures will occur in people who don't have osteoporosis by T-score definition. This is why it's important for us to ask, have you had a fracture? It doesn't matter what your T-score is. As I showed you previously, you could have a normal bone density and have had a fracture. For example, if you write a prescription for prednisone, 7.5 milligrams for 3 months or longer, your patient can come back in 6 months with a new vertebral fracture even before the bone density has had a chance to go down, because that prednisone is going to kill off their osteocytes. It's going to kill off their osteoblasts. It's going to decrease calcium absorption. It's going to cause a secondary hyperparathyroidism. It's going to cause central hypogonadism. All kinds of horrible effects are going to happen with no change in bone density. So bone density only is one small part of the picture. And we as physicians are treating patients, not numbers. We have to do a history, a physical, a lab profile, and capture all of this information that we've discussed. Have they had a fracture? How old are they? What is their bone density? And what are these other risk factors for fracture? What is their racial? What is their ethnicity? Asians and Caucasians are more likely to have fractures. Blacks have have a lower risk of fracture given the same bone density. But someone of African ancestry with steroid therapy or with diseases or drugs associated with bone loss or genetic predisposition can also develop osteoporosis for sure. So in people of all racial backgrounds, we need to be concerned about osteoporosis. We need to ask about family history. We need to look at their frame, petite frame. Are they tall? If they're petite, the bone density will be underestimated because DEXA does not adjust for height. And do they have other comorbidities like rheumatoid arthritis, which will result in increases in cytokines and increased rank ligand expression and increased bone remodeling, Parkinson's disease, decreased mobility, chronic obstructive lung disease. And then the modifiable risk factors, inadequate calcium and vitamin D, hypogonadism, inadequate physical activity. Maybe they have MS, smoking, alcohol, falls, drugs. All of those factors will have an impact, and we need to evaluate them. Alcohol, 3 drinks or more a day, high coffee consumption, four cups a day or more. I tell my patients to switch to tea because tea has estrogenic flavonoids and does have some degree of skeletal protection. So we need to remember that we need to understand that the clinical risk factors will have an impact, the bone density will have an impact, and we have to integrate that information in evaluating our patient's fracture risk. And we can utilize the FRAX tool or the CAROC tool, input all of this information with or without bone density, and we will get 2 pieces of information. We will know what our patient's major osteoporotic fracture risk is over the next 10 years, and we will also know what the hip fracture risk is. If the hip fracture risk is 3% or higher, they have to be treated, and they have to be treated aggressively. If the risk of a major osteoporotic fracture is 20% or higher, we have to be aggressive in our management. Now let's move on and look at evaluation of fracture risk. And we've really talked about all of these factors. And I just want to emphasize that look at what happens with age. This is an image of the hip in a young individual. You can see that the trabecular pattern is well maintained. There's connectivity. We've got a nice thick cortical shell. And look at what happens with age. Look at the cortical porosity that has developed. Look at the trabecular pattern. We've got trabecular dropout. We've got large gaping areas here, areas with no trabecular struts. And this person, if they fall, or even if they don't fall, they can have a femoral neck fracture. They could have an intertrochanteric fracture. The result of the impact on the geometry of the bone and the microstructure is going to dramatically decrease their bone strength. And we need to preserve the skeleton. And we need to recognize that if someone is falling, their risk of fracture in comparison to a woman without osteoporosis and without falls is much higher with osteoporosis and exponentially higher if they're falling. So this is important information that we as physicians need to ask about. How much alcohol are they drinking? That can double the risk of a hip fracture if it's 3 units or more. Alcohol actually has toxic effects on osteoblasts. It can be associated with hypogonadism. It can be associated with impact on neuromuscular function and on fall risk, and also affect bone remodeling. And the global longitudinal study of osteoporosis in women, the GLOW study, showed us that other comorbidities have an impact on fracture prediction. Parkinson's disease, MS, osteoarthritis, heart disease. And we've mentioned all these factors. And it's important for us to evaluate them. Similarly, we need to look at drugs, and drugs such as antidepressants, SSRIs, and SNRIs will have an impact on the serotonin receptors on osteoblasts and osteocytes, and will have an impact on bone remodeling and repair. Benzodiazepines and narcotics can have an impact on fracture risk by impacting fall risk. Anticonvulsants stimulate the hepatic microsomal enzyme system and result in vitamin D catabolism. Diuretics increase the trips to the bathroom at night. Anticonvulsants we've talked about. Aromatase inhibitors will decrease production of estrogen from the adrenal androgens, and they are associated with a decrease in bone density and an increase in the risk of fracture. And when our patients have postural hypotension, that's associated with an increased risk of falls. So we need to take a very careful assessment of their medications and recognize that these are possibly contributing to their fracture risk. Let's talk about medications. We've evaluated their osteoporosis. We know that they do or do not have secondary causes of osteoporosis. We've corrected the underlying conditions resulting in an increased risk of fracture. Now, which drug shall we give them? Well, what does Osteoporosis Canada say? And in our Osteoporosis Canada guidelines, we said that the bisphosphonates do have an impact on reducing the risk of vertebral, hip, and non-vertebral fracture. Denosumab reduces the risk of vertebral, hip, and non-vertebral fracture. Teriparatide, an anabolic agent, reduces vertebral and non-vertebral fracture, and in a recent meta-analysis also reduces the risk of hip fracture. And we know that in patients who have chronic kidney disease, we are not going to give them a bisphosphonate, but we can certainly give them denosumab because denosumab is not renally cleared. In patients who have gastroesophageal reflux, bisphosphonates are contraindicated. So if your patient is on a PPI or has dorsal kyphosis or complains of symptoms of reflux, please do not give them a bisphosphonate. If they have a high risk of fracture, we are going to make the best option, the best choice for them. And in the new Endocrine Society guidelines, patients who have a high imminent risk of fracture, we choose an anabolic agent. And this would be teriparatide or romosozumab. And if they're not able to go with that, my choice would be denosumab. And if they're not able to go with that, then I would give them a bisphosphonate. So we need to move with the times. And these are 2010 guidelines that I'm recommending and presenting to you, but we are updating these guidelines And we recommend aggressive therapy in patients who have a high fracture risk. Anti-resorptive therapy, we know, is associated with improvements in bone density. We cannot compare across trials because the results of the study are a reflection of the study in that patient population, but we can see that the anti-resorptive agents do result in improvements in bone density at the spine and at the hip site. Now, how long should we be treating our patient? And we know that osteoporosis requires long-term therapy. It's just like hypertension. Our patients need to be treated. We can't just stop therapy, especially if they have a high fracture risk. Now, we need to remember that bisphosphonates are unique in that these drugs remain in the skeleton for decades. So if our patient has been on bisphosphonates for 5 years, and if after 5 years, the fracture risk is moderate, and the femoral neck T-score is better than minus 2.5, and they have not had a fragility fracture, we can give them a drug holiday. We can stop the bisphosphonate, specifically in those situations. Moderate fracture risk, femoral neck better than minus 2.5, and no prior fragility fracture. After 5 years, we can give them a drug holiday and see them every 2 years and repeat their bone density and ask them if they've had any fractures. And if they're stable, we could continue the drug holiday. But if that's not the case, if the fracture risk is high, we need to continue drug therapy. And if we look at the impact of long-term bisphosphonate therapy, we can see that long-term bisphosphonates will have an impact on, let me just switch to the bisphosphonates and then I'll come back and show the denosumab data. We can see that long-term bisphosphonates have been shown to reduce vertebral fracture beyond 5 years. But we have not seen a consistent reduction in non-vertebral fracture risk with long-term bisphosphonate therapy. And we have not seen a consistent reduction in hip fracture risk with long-term bisphosphonates. So it's important for us to remember that bisphosphonates are best used for up to 5 years. After 5 years, we recognize that the risk of an atypical femoral fracture rises, and the risk of non-vertebral fracture and hip fracture risk may not be reduced. So it's important for us to recognize that. And if our patient does have a high fracture risk and they've been on bisphosphonates for 5 years or longer, my practice is to switch, and I would switch them to denosumab or teriparatide or romosozumab. But I do not continue long-term bisphosphonates because we have not seen reductions in non-vertebral fracture risk with long-term alendronate or zoledronate. And long-term bisphosphonates, we recommend that we proceed with a drug holiday if their T-scores are better than minus 2.5 and they have not had a fracture. If they have had a fracture or they have a high fracture risk or the femoral neck is minus 2.5 or less, they need to continue with therapy and we can switch them. Remember, these recommendations, we published this in 2014. And after that, the long-term denosumab data became available, showing us that teriparatide is able to reduce the risk of vertebral and non-vertebral fracture out to 10 years. And in that way, it differs from the bisphosphonates. So if their fracture risk is high or the femoral neck T-score is minus 2.5 or less, or they've had a prior fragility fracture, they need to continue with drug therapy. Now, I had skipped a whole bunch of slides because I just wanted to follow that line of thought with you. And now, what about long-term therapy with denosumab? So different to the bisphosphonates, Denosumab has been shown to prevent both vertebral and non-vertebral fracture out to 10 years. And in the FREEDOM study, we can see that if there was a placebo group and a long-term denosumab therapy group, and so the placebo group was switched over to denosumab, and then their risk of fracture declined, and this is for non-vertebral fracture, and the group that was on denosumab to begin with ongoing therapy, their risk of fracture declined further. So when we continue denosumab, we're preserving the cortical and the cancellous bone, and we're providing skeletal protection. We are providing further impact on reducing both vertebral and non-vertebral fracture. And we have the 10-year data, and you can see that this was published after that paper, which talks about drug holiday and when to switch to denosumab therapy. But the long-term data with denosumab has shown us ongoing benefit with non-vertebral fracture risk reduction in the years 4 to 7 and ongoing benefits. This was the long-term plus crossover and the long-term denosumab therapy. Patients who were on denosumab all the way out to 10 years, ongoing reductions in non-vertebral fracture. And why is that happening? It's because we're preserving and protecting the cancellous and the cortical bone. And if you look at what happens to bone density from the FREEDOM study, here it is. This is the denosumab group, and you can see that there's ongoing rises in bone density at the lumbar spine with denosumab. Here's the group that was on placebo, and when they were switched over, they had these dramatic rises in bone density associated with reductions in fracture, both vertebral and non-vertebral fracture. So we've reviewed this data, and we can see that there are differences amongst the anti-resorptive agents. It's important for us to emphasize to our patients that treating osteoporosis is going to provide them with a far greater benefit than the risk of osteoporosis therapy. In our osteonecrosis of the jaw systematic review and international guidelines that we published in 2015, that paper was published after this paper. And we said that the risk of ONJ with bisphosphonate therapy is close to 1 in 100,000 in the doses that we're using in patients with osteoporosis. The risk is 1 in 100,000. What is the risk of having a fracture with osteoporosis? If they have a high risk of fracture, their risk could be 20%, 1 in 5, or 1 in 4, or 1 in 3. These are big numbers. And we need to recognize that their benefit is far greater. Tell them your risk of having a fracture, a fragility fracture, is 1 in 4. Your risk of having an atypical femoral fracture is 1 in 1,000 with 10 years of bisphosphonates. And with ONJ, we're looking at 1 in 100,000. So your benefit is far, far greater than your potential risk. Now, remember, when we stop denosumab therapy, the benefit is gone because denosumab does not have long-term skeletal retention. It circulates in our bloodstream. It's an antibody. It's cleared through the reticuloendothelial system. And it will then result in an increase in bone remodeling and a rise in fracture. And we cannot stop drug therapy. It's just like stopping antihypertensive therapy. Our patient's blood pressure is going to go up. Their risk of stroke will rise. So when denosumab is stopped, what happens to the markers of bone remodeling? They go right up. The rate of osteoclast bone resorption goes right up. And what happens to bone density? It will go right down. 12 months after stopping, you're back to baseline. Absolutely critical that we explain to patients that when they stop therapy, they lose the benefit of therapy. And this is looking at multiple vertebral fractures, and the risk will rise when they stop therapy. So this is from the FREEDOM study, and the extension of the FREEDOM study. We can see that even when placebo stops therapy, their risk of fracture rises, just because with time, your risk of fracture will rise. But when the denosumab group stopped denosumab, the risk of fracture rose because now we've taken away the benefit and osteoclast function will once again resume and the fracture risk will rise. And it's important for us to explain this. So the discussion clinical takeaways are, there is no arbitrary time limit to osteoporosis therapy. As long as the patient has a high risk of fracture, they need to be treated. And if someone has had a hip fracture or a spine fracture or more than one fragility fracture, they will always be high fracture risk. If your bone structure looks the way that I showed you, it needs to be treated. There is no drug holiday for any of the other molecules. The drug holiday only applies to bisphosphonates. And in high-risk patients, switching from bisphosphonate to more powerful agents like denosumab or to an anabolic agent like teriparatide or romosozumab is very rational and evidence-based. And we need to move with the times. We don't ask our patients to use the steam train today. So we need to move with the times. We have now obtained very good evidence that anabolic therapy is the way to go after a fragility fracture. And if your patient cannot go with anabolic therapy, denosumab has a greater impact on the surrogate markers of fracture in comparison to bisphosphonates. Head-to-head data has shown us greater impact on bone density, greater impact on biomarkers. And a drug holiday is only suitable for patients after a bisphosphonate if they have a moderate fracture risk. And the femoral NAC T-score is better than minus 2.5, and they haven't had a prior fragility fracture. So with that, I'd like to thank you for your attention, and I'd be happy to answer any questions.
Thank you, Dr. Khan. Again, another excellent presentation by you. I've heard you several times, and I just learned so much every time. So thank you very much.
Thank you.
Many questions. So let's start with bone mineral density. How often would you do it, people who are taking treatment of some sort and who are on a drug holiday?
Thank you, Dr. Axler. So it's important for us to remember that we only do a test when it's going to make an impact on our management. And if we look at the rate of bone loss in women post-menopause, it can be about 1 to 2% per year. And with therapy, we will be able to reduce that rate of bone loss. And the least significant change at the spine, you need to have at least about a 3% change. So I wouldn't do the bone density sooner than 2 to 3 years in someone who is starting active therapy. And if they're not on therapy and they're having bone loss, then it could be repeated in 1 to 2 years. And if they're stable and they're doing well, then we don't need to keep repeating the bone density. So we don't need to do it every year. Maybe every 2 to 3 years would be appropriate.
Thank you. Someone says, I've always been confused by the T-scores and BMD reports. Can you please clarify how to use them to determine therapy and starting therapy?
Right. So remember that we measure the bone density in grams per centimeter squared with the densitometer, and then we compare our patient's bone density to the mean young adult reference range. And that comparison is called a T-score. It's reflected in the form of a T-score, which is the number of standard deviations that our patient differs from the young adult patient population mean value. And each standard deviation is a 10% reduction. So if you have a T-score of -2, that means you're 20% less than the young adult mean reference range. And if you're -2.5, then you fit the criteria for a diagnosis of osteoporosis, providing you are postmenopausal if you're a woman, or over the age of 50 if you're a man. Now, in younger people and premenopausal women, we don't use T-scores. We use Z-scores. So we would compare a 35-year-old premenopausal woman to other 35-year-old premenopausal women and do an age-matched comparison. And we say that a Z-score of up to 2 standard deviations is normal. And the reason why we use Z scores and say -2 is normal, up to -2 is normal, is because in all areas of medicine, we say that 2 standard deviations from the mean is normal. And we apply the same principle to bone densitometry.
Thank you. Why is an ankle fracture not considered a fragility fracture?
That's a good question. And when we look at these fractures, we want to look at how predictive they are of future fracture risk and how they correlate with bone density. And ankle fractures actually correlate more closely to BMI, to body mass index. So they're seen more commonly in obese individuals who can, sprain their ankle or fall over their ankle, twist their ankle, and that's when the fracture happens. And it's not as predictive of future fracture risk as some of the other fracture sites. But having said that, if someone has osteoporosis, they're more likely to have fractures of all types, including ankle fractures.
Thank you. You talked about fragility fracture being a fracture from a standing height, but what if you're doing an activity such as running or skating? Doesn't that change it slightly?
Yeah, so if there's more momentum applied, the force of the trauma will be more significant, and you're more likely to have a fracture. So this is why we differentiate traumatic fractures from fragility fractures, but we also recognize that someone with osteoporosis is also more likely to have fractures in a traumatic environment. So if you had a motor vehicle accident, the same degree of trauma, 2 people sitting in the same car, same exposure to the same degree of trauma, the person with osteoporosis is going to come out with more fractures than the person who has normal bone density and normal bone strength. So we have to kind of gauge that as well and take that into the picture.
Okay, thank you. Someone asked about wrist fracture counting as a fragility fracture. Is it not considered part of the hand, and would it not count? But I think if a wrist fracture is a fragility fracture.
Yeah, absolutely. You're totally right about that. So if someone says, I broke a bone in my arm, then we need to know, was it one of the carpal bones or was it the long bone? And so we absolutely need to know exactly where that fracture happened. And sometimes you need to get the X-ray report to know.
Thank you. You talked about 2 vertebral level. It means 2 different vertebrae, like L1 and L3. Is that correct?
Yeah, or they could be contiguous vertebral bodies. Yeah, but you need to have at least 2 lumbar vertebrae to make a diagnosis of osteoporosis at the lumbar spine. And if you don't have it, then that site is invalid and can no longer be used.
Thank you. People on bisphosphonates will have a fragility fracture, but that is not necessarily a treatment failure. Is that correct?
It's a sign that this individual needs more aggressive therapy, and we should optimize it. They're going to fractures just like people with heart disease. They're going to have an MI. Does that mean that the treatment that we're giving them is failing? Well, it means that, we could do a better job. Their disease process will continue to result in an increased risk of fracture. But if we can optimize their management, then we should. So if they were on bisphosphonates, I'd switch to denosumab. If they're on denosumab, I'd add in teriparatide or switch to romosozumab. But I wouldn't stop denosumab if I'm switching to teriparatide. Like I wouldn't go denosumab teriparatide. You add in teriparatide or switch to romosozumab. And the reason for that difference is that romosozumab does the work of 2 drugs. It's an anabolic and an anti-resorptive, whereas teriparatide is only an anabolic agent. And if we switch to teriparatide, our patient will have bone loss.
Okay. Someone asks, how do you manage osteopenia?
And that's a really good question. And we always have to look at fracture risk when we decide who to treat and how to treat. Because an 85-year-old woman could have a femoral neck T-score of -2.4, and she has, by definition, osteopenia, but her fracture risk is high. So we would be aggressive in management. So we have to look at the picture, the patient, how old are they? Have they been on steroids? And calculate the fracture risk. We need to treat based on fracture risk, not on bone density.
Yes, good point. Thank you. Are vertebral compression fractures comparable to fragility fractures for fracture risk?
Yeah, that's a very good point. And if a vertebral fracture happens without significant trauma, that patient, number one, has osteoporosis, and number two, they have a high fracture risk.
Thank you. Some questions on Depo-Provera, and I'll add in the implantable progesterones now. Should we be doing bone densities on these people? Should we be doing it before we start them on these treatments?
Yeah, and we have good data with Depo-Provera in young women, and we know that with 2 years of use or longer, there are reductions in bone density, and when the Depo-Provera is stopped, the woman will regain bone density, except in young girls who are started on Depo-Provera before the achievement of peak bone mass. And peak bone mass is achieved by the age of about 20 to 25. And if they are on Depo-Provera during these years when they are actually supposed to be accruing bone, when we stop it, they still don't achieve their genetically determined peak bone mass. So in comparison to their peers who are on estrogen-containing contraceptives, they will always be at a disadvantage in terms of their final achievement of bone density. So what it means is that we should be cautious about using Depo-Provera in young women who have not achieved peak bone mass. 20 to 25 is when that's achieved. And if we do use it for prolonged time periods, we should look at other risk factors for fracture and consider doing a bone density assessment and consider estrogen add-back therapy if the woman has a Z-score which is lower than -2 or -2.
Thank you. During this pandemic, should we consider holding off bone densities? I would think this question refers to following up on therapy.
Yeah, I think that, certainly we don't need to do a bone density if it's not going to make a difference in our management. It's always best to go by that rule. If it's going to make a difference, then you could certainly do a bone density test, especially if the patient has been vaccinated. If you want to know, should I treat this patient? Remember, we can do FRAX without BMD. And FRAX without BMD has a pretty good area under the curve. It's a very good predictor of who will fracture. It's a good model for us to use. And in our new OC guidelines, there will be a role for FRAX without BMD.
Thank you. Can you comment on osteoporosis exercise programs?
Yeah, these are important for us, for our patients to participate in. We want our patients to be walking, 5 miles a day is what I tell my patients. And if they're doing a lot of weight bearing exercise and core muscle strengthening, like plank exercises, that's all great. And Osteoporosis Canada has some excellent videos that are posted that our patients can access.
Thank you. You talked about the workup of the osteoporotic patient before we start therapy. Is it routine that we do every one of those tests?
It is important for us to spend the time up front, do our tests, know what we're dealing with. And then you can sit back and relax and start your patient on therapy. But you don't want to miss a secondary cause of osteoporosis. It is absolutely critical to do the workup. Yeah, I would definitely say that is essential.
Thank you. What about patients with eating disorders? Should we be monitoring their bone density?
Yeah, that's a very good question, John. And it's important for us to remember that young girls and also young men who can develop anorexia nervosa, because it can happen in men as well, do develop decreases in bone density and decreases in bone strength, and they develop fragility fractures. And it is absolutely important for us to not only give back estrogen, because these young women are hypogonadal, they also have a hypercortisolism state. So we need to give them back estrogen, but we also need to address the weight issue. And if we don't address the weight issue, we will not see the recovery in the skeleton that we would be able to achieve if the eating disorder is corrected. So it's not enough to just give back estrogen, and we recognize that transdermal estrogen is preferable over oral estrogen supplements because of the fact that the transdermal estrogen bypasses the liver metabolism, and it will not have the negative effects that we can see with oral estrogen. But we need to also address the eating disorder. And it's important for us to refer our patients to an eating disorder program or a clinic where the nutritional needs of that individual are also addressed.
Thank you. Last question. I'd love to go spend the rest of the afternoon. These are great questions. What do you say when the dentist calls you about your patient has ONJ?
First of all, I tell them to read our ONJ guidelines. We did a systematic review and developed the international guidelines for ONJ that was published in JBMR in 2015. And we were working with the oral surgeons, Canadian Oral Surgery Society, the Dental Association. We had a multidisciplinary approach to the development of these guidelines, and they've been summarized in a single and simple brochure, which is posted on Osteoporosis Canada's website. So I would say, give them the brochure, ask them, does the patient really have ONJ? If they have developed ONJ, then, there's treatment for ONJ, and that includes antibiotic mouth rinses and antibiotics. ONJ is osteomyelitis, and it's associated with a tooth extraction or a dental procedure. And if the patient is on high-dose anti-resorptive therapy, typically seen in cancer patients, then there isn't enough osteoclast activity present in the oral cavity to allow the bone to be removed and new bone laid down, so it can become infected and develop fistulas. But in osteoporosis patients, the risk of ONJ is very close to the general population because the doses that we're using are much lower than used in oncology patients. But if a patient develops ONJ, then we can certainly look at holding anti-resorptive therapy until the area heals. We may transfer this patient over to an anabolic agent such as teriparatide to allow increased healing. And in the oncology patients, if the patient develops ONJ, after it heals, we go back to anti-resorptive therapy because they're life-saving drugs. And we've done the same with osteoporosis patients. Once it heals, address the causes of ONJ. Is it poor dental hygiene? Is it periodontal disease? Is it poorly fitting dentures? What's the problem? Address that problem and go back on treatment for the osteoporosis. We've had so many patients admitted to hospital with multiple vertebral fractures. They didn't even have ONJ to begin with. And they stopped their treatment. So we need to approach this with a scientific perspective.
Thank you. We'll have to have you back just to answer all the questions. Many, many questions. It's a sign of a very good presentation. And so on behalf of all the attendees, thank you very, very much, Dr. Khan.
Thank you so much. It's my pleasure.
Thank you. So we'll take another 15-minute break, and our next topic is on diabetes. Thank you.
Bye-bye.